Hi everybody, I'm back, and you are too, I see you're here. Chapter 23 are drugs for neurological disorders, specifically Parkinsonism, Parkinson's disease, and Alzheimer's disease. And starting this off, and then we're going to go through and break it down a bit. We're going to look at the different meds, but we're also going to kind of compare and contrast Parkinson's disease and Alzheimer's. Then it'll help us look at the drugs. Both of these drugs are degenerative neurological diseases. If we compare them, we see that Parkinson's disease is caused by the decrease of dopamine and then the imbalance of both acetylcholine and dopamine. As far as the neurotransmitter in Alzheimer's that there's a problem, it is associated with the lack of acetylcholine. Parkinson's, the chief signs and symptoms we see with Parkinson's are rigidity of the musculature, bradykinesia, and tremors. And with Alzheimer's, what we see more related to a loss of memory, judgment, logical time, and orientation. So there's a big difference upon presentation, as well as the neurotransmitters that are causing it. Objectives here, look at the pathophysiology, where I've already started that, especially of the two disease processes here. Look at the drugs and drug classes that help these patients. Apply the nursing process related to the administration of these drugs and what we need to know and what we need to assess. First on board is Parkinsonism, pathophysiology. We did say it's a chronic neurological disorder and the imbalance of dopamine and acetylcholine. The reason for the degeneration of the neuron to begin with, those degeneration of the neurons of the extrapyramidal motor tract, we're really not sure of, but we know this imbalance of these neurotransmitters encourages this chronic and progressive disease process. We know that dopamine is an inhibitory neurotransmitter and acetylcholine is more of an excitatory neurotransmitter. Dopamine normally remains control of or maintains control of acetylcholine and inhibits its excitatory response to kind of level it out. In Parkinson's disease, there's an unexplained degeneration of the dopaminergic neurons and an imbalance between dopamine and acetylcholine occurs. With less dopamine production, acetylcholine is unopposed, causing excitation and stimulation of neurons that release GABA, and with increased stimulation of GABA, symptomatic movement disorders occur. Characteristics, we have some of these we've already said and others we haven't. Tremors, and these tremors are of head and neck to be more specific. Rigidity with increased muscle tone. Bradykinesia, this is slow movement. Postural changes with the head and chest thrown forward. They shuffle, they have a shuffling gait and a lack of facial expression. Don't forget about communication in our faces and how we use them. They kind of look real bland and uninterested. Pill rolling motion of the hands also is noted with this disease process. Treatment regimen, well, we already know that the acetylcholine and dopamine are involved here and the need both of having more dopamine and also leveling out that acetylcholine because of the imbalance. So on top, anticholinergic, benzotropine is given. A dopaminergic, then that's carbidopa, we're going to talk about that in a second, and levodopa. The carbidopa helps and more dopamine is made. Or converting of dopamine. Dopamine agonist or stimulants. One of these is amantadine, and it stimulates dopamine receptors. MAOB inhibitors, salicylamin, it inhibits MAOB, an enzyme that interferes with dopamine. So it kind of stops that enzyme and kind of allows some of that dopamine out there. COMT inhibitors, tolcapone, it inhibits COMT enzyme that inactivates dopamine. Some of the other anti-Parkinson's disease, you can also call these anticholinergics. You can call them the parasympatholytics, and they inhibit the release of acetylcholine. We said there's an imbalance, a bit too much acetylcholine. They are said to help also treat drug-induced Parkinsonism when a patient is given, for instance, antipsychotic from a phenothiazine category, which is one of our oldest for the antipsychotics. The meds here under the anticholinergics or parasympathetic. They inhibit the release of acetylcholine. We have cogentin here, artane, echinidin. The action inhibit the release of acetylcholine. They reduce the rigidity and some of the tremors characteristic of this disease process. There is minimal effect on bradykinesia. There's really not too many drugs that we have that even touch that, and they're used to treat drug-induced Parkinsonism or pseudo-Parkinsonism. Nursing interventions, of course, monitoring vital signs, watching the urinary output. We want to detect if there's retention starting up. Increase fluid, fiber, and exercise. Observe for involuntary movements. Advise patient to avoid alcohol, cigarettes, caffeine, and aspirin to decrease gastric acidity. And we want them to encourage to relieve that dry mouth with sugar-free candy, sugar-free gum, ice chips. And we're going to suggest pretty highly that they wear sunglasses for photophobia. All right, we kind of just talked about that and thinking about your assessment, seeing where they're at, what their optimal level is, what their goals are. Safety is a big concern here with these folks. We want to watch tremors. We want to keep them at their optimal level for as long as possible. We want to do a lot of education related to taking these medications. We're going to talk some more about that. More anti-Parkinsonism drugs. The dopaminergics, we have the carbidopa, levodopa, or cinnamate. It is converted to dopamine. This increases mobility. We want to watch out for some of these side effects: insomnia, dry mouth, blurred vision, lowered blood pressure, especially with standing, orthostatic hypotension, in other words, palpitations, dysrhythmias, urinary retention, nausea, vomiting, dyskinesia, psychosis, and severe depression. Drug interactions. Unfortunately, the more anticholinergics we put on, the more side effects they're going to have. If they're on Dilantin, we got to watch that very carefully. Tricyclic antidepressants such as Elavil, the prototype, we're going to talk about that as we get on down to that chapter. MAO inhibitors, benzodiazepines, phenothiazines. Phenothiazines are like thorazine or chlorpromazine, our first antipsychotic. Also in this category is phenerganocomazine, or some of our older antiemetics, and vitamin B6. We have to be careful of all these drug interactions. Speaking about these drugs, how about carbidopa, levodopa? What does it do and what are the advantages? When levodopa is used alone, only 1% reaches the brain because 99% converts to dopamine while in the peripheral nervous system. When we combine the levodopa with carbidopa, we find that the carbidopa can inhibit the enzyme breakdown in the periphery. Thereby, it allows more of that levodopa to reach the brain and convert to dopamine. The dopamine agonist, okay, what helps with the receptors and stimulates the dopamine receptors? Medications, amantadine or Simitril. It's also used as an antiviral for influenza A. It does stimulate those dopamine receptors. Taken alone or in combination with that levodopa, it is anticholinergic. Use early treatment of Parkinson's as drug tolerance develops and improvement of symptoms. Nursing intervention, still monitoring for the blood pressure, administer it with low protein foods. It sometimes does bother the belly, but if we give high protein foods, it's going to have trouble absorbing. We want to avoid vitamin B6, alcohol, and other depressants, and we do not want to stop this quickly. We want them to talk to their healthcare provider and see what's going on. Warn patients of harmless brown discoloration of urine and sweat. It is harmless. Assess for suicidal tendencies. Think about them having Parkinson's to begin with. Assess symptom status. Monitor blood cell counts, liver and kidney functioning. Talked about the drugs being taken with low protein. Let's see, some of the foods you want to avoid then, if we're going to avoid some of that vitamin B6 in excess, we want to watch how many lima beans we eat, navy beans, kidney beans, cereals, and vitamin 6. What it does is it does inhibit the conversion of levodopa to dopamine, which these patients are lacking dopamine to begin with. Now we're on to Alzheimer's. We started at the beginning of the show and we talked about, for this lecture, the compare and contrast. Now we're going to hit it again. Pathophysiology, it's incurable. Parkinson's is incurable as well. It is a chronic progressive neurodegenerative condition, marked cognitive dysfunction, onset. It says it usually occurs 45 to 65. We rarely see somebody 45 with it. But this disease starts earlier. We just don't pick up on the signs and symptoms if we could only pick up much earlier. Usually they will break this down into patients before the age of 65 and after. There are plaques in the brain. These plaques in the brain on the nerves, they keep messages for going through. There are also neurofibrary tangles in neurons and cholinergic neurotransmitters that are abnormal. And there are amyloidopla, I'm saying that incorrectly. There are plaques of protein that settle in the brain. Apolipoprotein is one, and beta amyloid, protein is another, and they contribute to this neuronal abnormality and these plaques and tangles. And here you have a picture in the histology. You can see the top neuron is normal, the bottom one is full with tangles in there. It's a wonder any message gets through. Symptoms, this is different than Parkinson. We see the slowdown, the rigidity, and pill rolling, more body-like. In Alzheimer's, we see more mind problems going. Memory loss, confusion, inability to communicate, aggressive behavior, depression, psychosis. And this progresses to loss of memory, logical thinking and judgment, time disorientation, personality changes, hyperactivity, tendency to wander, inability to express oneself, and later hostility and paranoia. Meds that are used, acetylcholine esterase inhibitors, because we want to use that acetylcholine, not break it down, and choline esterase inhibitors. So we inhibit that enzyme in breaking it down. And some of the meds we use for this is Tactrin or Cognix, donepezil or Aricept. We have Exelon, we have Ronzidine, and these meds you're going to see out there, they allow more acetylcholine in the neuron receptors and increase cognitive functioning. They're trying to slow it down. There is no cure at this point. Exelon is a acetylcholine inhibitor, acetylcholine esterase inhibitor, so it doesn't want to allow that enzyme to break it down. It's prescribed to improve cognitive function for patients with mild to moderate Alzheimer's disease, increases the amount of acetylcholine at the cholinergic, synapses, and slows the disease process. There are fewer drug interactions than with Aricept and Tactrin. Exelon, side effects, anorexia, nausea, and I would say nausea is probably the biggest thing I've seen with some of these meds, and it's not even been a whole heck of a lot. Vomiting, diarrhea, constipation, it kind of goes on. You see restless leg syndrome, nystagmus, adverse reactions, and these are serious side effects or adverse reactions: seizures, bradycardia, orthostatic hypertension, cataracts, myocardial infarction, and heart failure. So the assessment here, we're going to watch the vital signs. We're going to watch and keep them as safe as possible, but also keep them involved in their life as much as possible. Vital signs are being taken, weight. We're going to, do all those things that we mentioned with this medication administration. All right, now we have a few case studies here, a few questions. A patient has been diagnosed with Alzheimer's disease. The patient's daughter asked the nurse what the cause of Alzheimer's disease is, and the best response by the nurse is, the cause of Alzheimer's disease is A, a virus, B, a cancer, C is unknown, D is normal aging. Unfortunately, the answer to this is that we do not know. It's C. The cause is unknown. There's a lot of speculation and different white papers out there, but nothing conclusive at this point. Another case study. This is the second one. The patient is prescribed Exelon. The patient's son wants to know how many times a day his father will need to take this med. The nurse informs the son that Exelon is usually taken how many times a day? It is usually taken twice a day. Here we go, another one. The nurse should teach the patient's family to administer the Exelon, A, without food, B, with meals, C, at 3 a.m. and 3 p.m., crazy, D, when the patient is acting most confused. Now with Exelon, we will find that food will decrease the absorption, so A is the answer here. It is best administered without food. Practice question 1. Which comment to the nurse indicates more teaching is needed for a patient taking carbidopa and levodopa? A, I know I need to take this drug once a day. B, I know I shouldn't stop taking this drug abruptly. C, I understand my urine may become dark and discolored. And D, I know it may take a few weeks or months to control my symptoms. The answer here is A, and our rationale with that statement, I know I need to take this drug once a day, indicates that more teaching is needed because carbidopa and levodopa has a very short half-life, and it's got to be taken 3 or 4 times a day. The other answers are all true. Practice question 2. Which side effect or adverse effect of carbidopa, levodopa does the nurse realize is most important to monitor? A, dysphagia or swallowing problems. B, increased libido. C, agranulocytosis, or a breakdown in white blood cells. D, urinary retention. It is C, agranulocytosis. Rationale, it's very important for the nurse to monitor the patient taking carbidopa, levodopa for agranulocytosis, which is a decreased white blood cell. It is life-threatening. Dysphagia, increased libido, and urinary retention are not at that point of life-threatening range as would be agranulocytosis. Practice question 3. Before administering the carbidopa, levodopa, or Sinemet for the treatment of Parkinsonism, it is most important for the nurse to assess the patient for a history of A, pulmonary disease or lung disease, B, diabetes, C, allergy to penicillin, D, glaucoma. It is D, glaucoma. Contraindications to therapy include narrow angle glaucoma, severe cardiac disease, and suspicious skin lesions. Practice question 4. A patient with Parkinson's disease is being treated with carbidopa, levodopa. The patient asks the nurse why he needs both. The nurse responds, A, the 2 medicines together are doubly effective. B, this combination has fewer side effects. C, you'll tolerate this better. D, the carbidopa helps the levodopa reach the brain. And the question, or the answer, is D. The carbidopa does help the levodopa reach the brain. Because of the side effects of levodopa and the fact that so much levodopa is metabolized before reaching the brain, an alternative drug, carbidopa, was developed to inhibit the enzyme dopa decarboxylase. By inhibiting the enzyme in the peripheral nervous system, levodopa reaches the brain. The carbidopa is combined with levodopa in a ratio of 1 part carbidopa to 10 parts levodopa. Practice question 5. A nurse at an adult daycare center notes that many patients are on Exelon. The nurse knows that the function of this med is to A, increase physical mobility, B, cure Alzheimer's, C, slow the progression of symptoms of Alzheimer's, D, restore full memory to the patient. I wish. It's C, slow the progression of symptoms of Alzheimer's disease. We've come to the end of our chapter today on neurological disorders, Parkinsonism, and Alzheimer's, and I will see you for one more chapter in this lecture. Have a great day or a great evening.